Before I got really involved in uterus transplantation, and I'm happy to talk about that with those that are interested. Really, my first love in medicine was trying to find ways to preserve the fertility for women and young girls who had been diagnosed with cancer. And this is an area of medicine that has had incredible changes over the last several decades. And so, yes, we continue to serve women and young girls that have survived their cancer diagnoses. Those are called survivors, obviously. But now there's a new term, which is previvors. And the thought is that we can identify women and girls that may be at risk of developing conditions that may threaten their fertility. And that's certainly the new wave. So we have patients at the moment of diagnosis, patients before they've ever been diagnosed, and patients that have survived their cancers and are now thinking about growing their families. So that's the population that we're going to focus on today. So I don't have any financial relationships to disclose, but I do have a personal relationship, as so many of us do, that enter into this work. And so just to share kind of how I got my start in fertility preservation, when I was studying for medical school, I had a best friend, a girlfriend, and she and I lived in an apartment together. We worked together. We, went to the same stores. We had the same friends. We dated the same boyfriends. And she and I were very, very close. And as we were in the process of applying to medical school, one day she came to work. We were working in a doctor's office, and said that she was feeling really tired. And that, she had gotten a massage and there were bruises all over her back. And so those of you that are medical would know that these are major warning signs that something is significantly wrong. But at the time, we hadn't even started medical school yet. And so we sent her blood and it came back looking like this, full of blasts. And she was diagnosed with AML later that week, and she started her chemotherapy the next week. And it's a happy story. She survived. She actually was successful in finding a match for a bone marrow transplant. But nobody ever talked to her along the way about the fact that the treatments that she would receive would threaten her ability to grow a family someday. The focus was so much on getting her treatment and getting her well that they forgot that there may be another side and that she would be looking to grow her own family. And so she's a physician now, as I am, and I think we both learned so much through the process. But the thing I learned the most was we need to be having these conversations with women. We need to have them early, we need to have them often, so that women are aware of what all of their options are in the context of a cancer diagnosis. And so these are my objectives for the talk today. Just to really talk about the importance of fertility preservation as we counsel reproductive aged women that are engaging in therapies that may compromise their future fertility. The second goal for today is to talk about all of the things that are available, including egg freezing, embryo freezing, genetically testing embryos so that offspring can avoid development of a cancer syndrome. And then, of course, all of the surgical things that we can do to preserve women's fertility, including ovarian tissue freezing. And I actually added a slide on sort of what's new, which is uterine transposition. And so there's been a lot of discussion about that recently, and we'll touch on that as well. One of the most important things to really recognize in the course of this lecture is the impact of aging on female reproductive success. And that goes for any of the fertility preserving methods that we're going to talk about today. And then lastly, to make sure that we cover the use of medical treatments in fertility preservation for female cancer patients. So those are the goals for today. We'll see what we can get to in an hour. So these are real cases of women that I've treated over the last probably 10 years. This is a very typical presentation, a young woman, 33, who's been diagnosed with receptor positive breast cancer. She does have a family history that would probably raise a few eyebrows. She had a maternal aunt with perimenopausal breast cancer, as well as a maternal great-grandmother with colon cancer. She did undergo BRCA testing and was negative, and she was scheduled for a lumpectomy followed by radiation. And so she comes, and these consults are always, in the middle of the night or at some very inconvenient time, but it's urgent. And so we have to give them all our full attention. And so this was a patient that came through. Now this is sort of your classic previvor. a 23-year-old G0 from a high-risk subtype, which is Ashkenazi Jewish women, known BRCA1 genetic carrier in her family, and then both her mom and her aunt had breast cancer, and that was how this mutation was discovered. So this is a non-urgent consult, but it's someone that we've identified may be at increased risk, and she wants to know what can we do for her to preserve her fertility, knowing that a cancer diagnosis may be in the next 20, 30 years for her. And then lastly, this is probably the youngest patient I've done fertility preservation on, not with cancer. She's a 6-year-old who had a diagnosis of aplastic anemia and was pending a transplant. And so clearly that has significant impact on future reproduction. What can we do for this young girl who hasn't even started puberty yet? So these are real world cases of things that I've seen in my own clinic. Oh, sorry, it's a little out of order. Case 3 is a patient that has known Lynch syndrome and a new diagnosis of colon cancer. So these patients get both chemotherapy, which can have impact on the ovaries, as well as surgery followed by radiation, which can traumatize the ovaries and the uterus additionally. So everybody here probably knows that cancer is common, and this is focused on the US, but the numbers are similar around the world. And cancer does not affect just men. Here you can see that actually women have higher numbers of cancer diagnoses than men, just by a little bit, in 2017. And many of these patients are actually in a reproductive window. So if we think that reproduction really starts to trail off at 45 and beyond, about 10% of this group of 850,000 women in the United States that we're looking at are in a risk group for impact to their ability to have a family. And the good news is, of course, that many women are now surviving their cancers. So there's a significant emphasis on survivorship. And part of that emphasis is making sure that we are attending to their reproductive concerns. And cancer is not something that just happens in adults. All the parents in the room probably share my fear of what this would be like to go through a diagnosis of cancer in your child. And in 2016, there were at least 10,000 children in the United States that were younger than 15 who were diagnosed with cancer. Now, a cancer diagnosis in childhood isn't today what it was in the 70s. You know, in the 70s, there was a 5-year survival rate of somewhere around 60%. Now we can be encouraged that most children that are diagnosed with cancer are going to go on to survive their diagnosis. But we're really interested now in what's called late effects, which means what does that look like down the road, 5 years, 10 years, 20 years? And we're really only just getting a good understanding of that now. So late effects is going to be, I think, a major topic of conversation in the survivorship field. Now, the Institute of Medicine in the United States does have specific recommendations, and these are continually evolving, but a survivorship care plan, and I kind of highlighted it here, really is required to include potential effects of cancer on relationships, on sexual function, and parenting. And then specifically down in number 10, fertility referral is a recommended component of a survivorship care plan. So these are things that are really clearly spelled out in literature. And if we're not doing this, this means we're truly falling short of the goal and the gold standard for fertility preservation. I always tell my team, my goal is not so much that every person, every woman or child, every man that's diagnosed with cancer, that they choose to pursue fertility preservation. That's not my goal. That's a personal decision. But it is my goal that every person who's diagnosed with a cancer has an opportunity to connect with an expert, to talk with them about what the risks are, to talk with them about what the treatment options are, and then to make a personal decision about what's right for that individual and their family. So the next slide is to say that there's really these 3 populations that we're becoming increasingly aware of. We've done a pretty good job of improving consultation for the newly diagnosed. I would say that most cancer centers in the United States now have 24-hour options for at least a fertility consultation. And our goal is to get that patient in within a day or 2. And that's the fantastic thing about telemedicine, is that, you know, the hospital system where I work has dozens of areas where a patient may be seen. Now with an iPad and a telemedicine visit, I can reach any patient anywhere, because most of what we do is talking. And so telemedicine has really increased our ability to get patient access when needed for newly diagnosed patients. But there are two other populations, and I would say over the last 10 years, I've seen a significant uptick in visits for previvors, so patients that have never even been diagnosed with a cancer but are at risk because of their personal or family history, and then survivors. And of all the patients I see, survivors are sort of the group that's the hardest to help, because most of the things that we do are supposed to be done before they start treatments. Once those treatments are done and eggs and ovaries have been damaged or lost, there's not as much that we can do to preserve a woman's options for getting pregnant using her own eggs. And so that's the group that, obviously we'll see and explore options, but there's not as much that we can do that far down the road. I think we need to recognize that although women and young girls are often surviving their cancers, that the diagnosis itself is life-changing for a young woman. And even many years down the road, the lingering effects of both the cancer and the cancer treatment have significant impact for these young women. So I think at worst, we see amenorrhea, meaning that they completely stop having their periods. And then more subtly, sometimes just menstrual disturbances. And one of the later slides that we're going to look at is really to say that, before, the metric that we used to look for was whether women completely stopped having their periods. And if they continued to menstruate, we felt like they were okay after cancer treatment. That's absolutely not true. And subtle menstrual disturbances can be a real red flag that something is very wrong for that individual on the other side of their cancer treatment. Women who've had cancer also often undergo either subfertility, meaning a decreased chance of getting pregnant, or infertility, meaning that they are sterile and unable to conceive using their own eggs. And then lastly, primary ovarian insufficiency, which means that the surgery or the radiation or the chemotherapy that they have encountered has completely depleted the ovarian reserve, or the supply of fertilizable eggs in the ovary. So there are significant consequences, and along with reduced fertility, and I see this every day in my run-of-the-mill fertility population, you see that women who've undergone cancer treatments and then have difficulties getting pregnant, they have high levels of depression, high levels of anxiety. Suicide attempts are not uncommon in this population. They also have significant regret because there's so much momentum towards the cancer treatment that at the moment that fertility preservation was offered and they declined, now years down the road, they wish that that had been a yes. And then lastly, increased risk of personal and marital stress. And I can't tell you how many times I've seen good couples, healthy couples, end up going through divorce because of an inability to get pregnant or stay pregnant. So it's really a devastating moment to be diagnosed with cancer. And then it's oftentimes a difficult path for the decades after cancer in trying to piece together what life is going to look like. And then I think this is also an interesting new avenue for the survivorship literature, which is that, we focus so much about the fact that when the ovaries are depleted of eggs, we can't have a baby. But there's actually so much more that goes with ovarian insufficiency. So when the ovaries stop making eggs, they stop making estrogen. And estrogen is a core reproductive hormone that helps us feeling good, that helps our bodies be healthy. And so many of these women manifest significant mood disturbances and require therapy or counseling, sometimes medical treatment. They also have significant sleep disturbances, and hot flashes often accompany that at night. There are marital impacts because of vaginal atrophy and sexual pain disorders. And then osteoporosis often will plague women who have low estrogen, because everyone knows the effects of hypoestrogenemia on low bone mineral density. So these are patients we have to watch very carefully with DEXA scans, because even if they're having regular periods, we will often pick up on osteoporosis. And then we talked about the hot flashes, which can be very debilitating, as well as infertility and subfertility. And these patients often are not like typical patients where we can just add estrogen or other hormones to help them feel better, because some of their cancer diagnosis may have included an estrogen sensitive tumor or condition. So we can't just throw estrogen at it because of potential risk of recurrence. So these are very complex to treat and really require a multidisciplinary treatment team. So I think where we can really do better, and this is across the board in every country, in every hospital, is just making sure we're having the discussion. again, there's so much momentum and there's such a highly emotional context when a cancer is diagnosed that sometimes this just gets completely skipped over. So this was an interesting study that was published in 2015 when they looked at breast cancer patients younger than 40. So these are women who absolutely should be getting a fertility preservation consultation. Only 55% of these patients actually had documented counseling, so right around half. And the part that concerned me the most actually was that it seems that people are assuming that a woman over 35 or a woman that's had a baby before is not interested in fertility preservation. But the fact is, we've got really good data that these actually are the women who want it the most, because greater than 35, they already feel like time is running out. And women that have experienced parenthood often really grieve the opportunity to have a sibling for their child. So we have to make sure we're having the discussion with women that are greater than 35 and women that have previous children. And then the other interesting thing about this study was that only about half of them actually correctly recalled whether they even had counseling, which just tells you the headspace that women are in when they're being diagnosed with cancer. You might be thinking you're doing a good job by having the discussion, and maybe it's even documented in the medical record, but half the time the patient doesn't even remember that it was discussed, or we're documenting incorrectly. And that's kind of what I gathered from that study. It's clear that only a minority of women who receive fertility preservation counseling actually do go on to freeze eggs or embryos. We think that that's largely because of time constraints. They either don't have the time to do it, or there's a perception that they don't have the time to do it, and also because of the financial burden. So I'm not sure exactly what the costs are in Egypt, but in the United States, egg freezing can easily cost $10,000 to $15,000. And you can add at least another $5,000 to do embryo freezing. So these are significant costs, and to ask someone to come up with that kind of financing in the middle of being diagnosed with cancer is really unfair. And we've made significant strides in the United States getting coverage for women who have insurance, that that insurance would then cover fertility preservation. I think it's now in about 8 states or maybe 10 states. Don't quote me on that, but we're making progress. And I think as the dominoes start to fall, the hope is that in every state we'll have mandated coverage for fertility preservation. I'd love to know what that looks like in Canada or in Egypt. But fertility preservation in men versus women reveals a significant gender gap. So if we have men who are diagnosed with cancer, usually about 60% of them will undergo sperm freezing, which is fascinating. But 2% of women that receive fertility preservation counseling in the context of a cancer are actually going to move forward with egg or embryo freezing. And again, probably related to time, cost, overwhelm. But it's really interesting to note the huge gender gap that we see. And then I do a lot of fertility preservation counseling in pediatrics and adolescent patients. And I think we really need to recognize that this is a totally different group of people, different priorities, different interests, different worries. And as you can imagine, it's hard enough talking to a 35-year-old about losing her ability to become pregnant. But imagine talking to a 15-year-old about it, or a 5-year-old or a 6-year-old. Sometimes they feel uncomfortable. Other times they just don't even know what you're talking about. So adolescents are classically uncomfortable talking about infertility, menopause, sexual function, vaginal pain. And in children, honestly, it would be years before their brains are at a point that they can even have a conversation about reproduction or sexual function. And another interesting thing that could be a whole different lecture is sort of the ethical considerations around who should be offered fertility preservation. Should it only be people with a good prognosis? Or does everyone deserve a chance to talk about decisions they might have to make in 5 years or 10 years, even if it's only a 1% chance that they're going to get there? And then I would say about once a year, we get a consult to do what's called posthumous fertility preservation, meaning sadly that someone has passed and we're asked to usually extract sperm after they've passed to see whether we can freeze that to be used in the future. And the ASRM actually has a practice bulletin, I believe, about that, just because ethically it's very fraught to have those discussions. It's important to know that these are not uncharted waters. There are many people and many professional societies who've made clear recommendations about the importance of fertility preservation. So both the ASCO and the ASRM stand behind essentially a need for universal consultation for people who've been diagnosed with cancer. This slide, I think, is really, really important if you're ever in a position of trying to determine if there's going to be reproductive harm from chemotherapy. One of the things that has clearly emerged is that there are certain bad actors, and they're always the same ones, that really threaten a woman's ability to have babies in the future. And the high risk level are either getting a bone marrow transplant, usually that's a hard stop to someone's fertility, or total body irradiation or pelvic radiation because of the effects of radiation on the uterus and the ovaries. And then lastly, probably the most common one is cyclophosphamide or Cytoxan, to the point that doing a cyclophosphamide equivalent dose, a CED, has become a really routine part of fertility care to figure out, is it past that critical threshold where we know that women will develop ovarian insufficiency from this particular chemotherapeutic agent? So cyclophosphamide, Cytoxan is really the name to know. The others are used less often, the nitrogen mustards, melphalan, busulfan, procarbazine, chlorambucil. Those are really like the most risky, but also not very commonly used. And then there's a bunch that are sort of in the medium risk, and then there are some that we know are generally pretty benign. So for example, this week I saw someone with a new lymphoma diagnosis. She's going to get ABVD, which is basically actinomycin, bleomycin, vincristine, and doxorubicin. And we know that overall, as long as they stick to that regimen, it should be pretty low impact on the ovaries. And so it's really a gift to be able to reassure that family and their young daughter that coming out of ABVD treatment, she should really have very little impact on her ovaries. But one of the things that we're understanding, and this is important, is that I don't know how many of you work with our oncologists, and at least in the United States, all the regimens are kind of what we call alphabet soup, meaning it's RCHOP or ABVD, and it's a bunch of, alphabet strung together. And so some of the problems associated with multi-agent regimens where women are getting exposed to 4, 5, 6 different chemotherapeutic agents is that whereas any one of them might be low in terms of their level of risk, once you combine different chemotherapies, that can be significantly more toxic. And so we have to really make sure that we're looking at the sum of all the parts rather than just an individual agent. One of the things that I will often use in helping me figure out how significant a chemotherapy regimen is going to be is an online resource called Livestrong, and they actually have risk predictors where you can put in someone's age, their chemotherapy regimen, and then it just kind of spits out what they think the risk is likely to be. So I use these all the time. Again, we're not oncologists, and so we need to be able to interpret the chemotherapeutic regimen and anticipate what the risk is going to be to that woman. Okay, so the next concept that I wanted to review, and this, in the course of all of these webinars, this may be something that is talked about multiple times in multiple settings. And this is a huge theme in reproductive medicine, which is the idea of the ovarian reserve. So if you can see on the picture here, the ovarian reserve really refers to what's in the tank. How many fertilizable eggs are still in that resting pool in the ovary. And as you can imagine, it starts here and it kind of starts to come down as we get older. And there are things that can happen that impact how fast it comes down or how it comes down. And so there have been multiple proposed biomarkers of the ovarian reserve. Probably right now, anti-Mullerian hormone, which is what's secreted by the small antral and preantral follicles, is probably the king. That's because the others tend to fluctuate, or for example, the antral follicle count, which is an ultrasonographic criteria, is very dependent on who you have doing the ultrasound and interpreting the ultrasound. So AMH has really emerged kind of as the king. It's not perfect. We have more data now that, for example, being on a birth control pill may make it less accurate, or even for cancer survivors, it seems to not be very accurate as a measure, but it's the best thing that we have. And so we are studying the AMH really actively in women before, during, and after cancer therapy. And what we found when we look at AMH is that these decreases we see after cancer therapy are related to two critical things. One is the dose, especially the cyclophosphamide equivalent dose. And the second is the duration of exposure. Obviously, more is worse, less is better. The problem with ovarian reserve for women, unlike men, is that the ovarian reserve cannot be restored. So once eggs are lost in the ovary, that's pretty much it. There's no stem cells that we can use, at least at this point, to reinvigorate the ovaries. And so that's really a key concept for when we think about surgery or radiation or chemotherapy, because once those eggs are gone, they're gone. And I think the other key point that we've learned over time is that the impact of some of this harmful chemotherapy that we're giving is really the greatest for women who are 35 and up. So you can take a 20-year-old and the chemotherapy that you give may wipe out half of her eggs, but she still has half of that component of 20-year-old eggs. You can take a 39-year-old and give her the same chemotherapy, and because she's already come down to here just by virtue of her age, that may be the end of her ability to get pregnant. And so age at the time of exposure is another key concept. The next slide, and this is very busy, but it's really just to show that women are born with a certain number of eggs. I suspect that some of us have more and some of us have less, even at birth, and that egg supply changes with age. I think it's sort of a little known fact that most of us have the highest number of eggs that we're ever going to have while our mothers are still pregnant with us, about 7 to 8 million eggs. And by the time that we're born, that has already come down in a major way to the point that then we may just have 1 million or 2 million eggs. By the time that we're 35, we may just have a few tens of thousands of eggs. And by the time we're 50, essentially our egg supply is depleted. And that's really when we get towards menopause. So this is an irreversible and sort of inexorable downward progression in terms of the eggs that we have. And when you feature cancer into the picture, and I will fully admit I made this slide myself, so sorry if it's not so flashy, but the slope of that line changes dramatically after fertility treatments. So somebody may not go directly into premature menopause after cancer therapy, but you better believe that they need to start getting pregnant as soon as they possibly can, because they're not going to be somebody who has menopause at 50, 51 like the rest of us. So actually a big part of what I do in my counseling is talking about family planning and expedited childbearing, because we don't know when and whether their fertility is going to start to steeply decline because of the treatments that they got. So they may be okay a year after their cancer therapy, but I don't know about 5 years or 8 years from then. Now this is, I think, again, like a really important slide, and this is from the California Cancer Registry of, hundreds of patients. And really what it shows here is that key point we were talking about, which is that the resumption of normal menstrual cycles after chemotherapy does not in any way equate to fertility. Fertility and menstruation are actually like somewhat uncoupled in the post-cancer patient. And so, like, for example, if you look at the chance of someone encountering infertility despite their periods coming back for, let's say, breast cancer, which is this, I don't know if you can see my mouse, but this blue line here, I mean, it's incredible how monumentally that starts to rise, especially in our older patients. And this is despite having completely normal menstrual cycles. And then all the other cancers that they looked at, the lymphomas, GI tumors, the bloodborne leukemias, all of those have a similar progression where it increases with time, although not quite as dramatic as the slope with the breast cancers. So periods do not equal fertility. That's really the key point. We have to think about other ways that we damage the ovaries, especially in the context of cancer, because now, especially these days, someone might have surgery and radiation and chemotherapy and long-term suppression of the gonads. And so we have to really think about all of the different ways in which we may impact ovarian function. So there's a concept with radiation, because the ovaries and the ovarian follicles that contain the eggs are very sensitive to radiation damage. The concept that we use here is called the LD50, and that's basically the dose at which half of your eggs will be lost with radiation. So, in the old days when I started doing this, the thought was that 4 gray, which is, a quantifier of the radiation exposure, would be enough that half the eggs are lost. And now newer studies are showing even less than 2 gray can result in permanent loss of eggs and ovarian function. And just like we see with chemotherapy, it's the dose, it's how long you're getting it, and it's how old that woman is at the time that her ovaries are being exposed. And this is really what's led into some thoughts about transposition, which we'll talk about in just a little bit. The newer frontier that we're starting to think about are the effects of radiation on the uterus, on the ability of the uterus to hold a pregnancy, continue a pregnancy, to perfuse a placenta normally after radiation exposure. And so that's a really active area of interest and research. We've focused so much on the ovaries in the past, but when you do pelvic radiation, it's both the ovaries and the uterus that are affected. And then, of course, another way that we damage the ovaries is through invasive surgeries. And so there's different techniques that we can use to minimize damage. There's also surgical treatments to get the ovaries and the uterus up and out of the way, so that the surgeries that are undertaken impact them less. So what are the overall categories of fertility preservation options? They are pretty wide. And they are getting wider with time, which is exciting. There's an incredible amount of creativity in the fertility preservation space. And we've actually been able to take a lot of what we've learned with reproductive transplantation, uterine transplantation, which is my other love, to looking at ovarian transplantation and uterine transposition. So as far as fertility sparing surgeries, obviously we can always preserve the uterus by doing just a trachelectomy. That would probably be most important for cervical cancers. And I've worked with many women after that who've been able to maintain their uterus and have a pregnancy even without a cervix. Ovarian transposition, uterine transposition. For medical therapies, there's a lively discussion going on in our field about the use of Lupron or GnRH agonists. I should note that this is particularly useful in women that have a functioning hypothalamic pituitary ovarian axis. So a lot of the consults I get for children are to ask, well, there's really not time to do anything else. So can we just give Lupron, an injection of Lupron to shut down the ovaries? And the answer is no. It's really an unnecessary injection in a pediatric patient. This is something that's suitable for women who have had, start of menstruation and who have a fully matured and functioning HPO axis. Then there's the assisted reproductive technologies. And despite the fact that I'm giving this lecture, most of my life is as an IVF physician. So egg and embryo freezing are huge parts of what we do. And actually in the introduction to the course, someone had asked if I could just spend a couple minutes talking about elective egg freezing, which is another topic that I am really passionate about. So these are women who don't have cancer, who wish to defer their fertility or preserve their fertility for other more elective or social reasons. There's a ton of that going on around the world. And we can apply what we've learned from the fertility preservation space to elective egg freezing. I'm happy that for the purposes of this talk, I was able to move ovarian tissue freezing out of the experimental column and into the assisted reproductive technologies. So for over a year now, ovarian tissue freezing is no longer considered experimental. This is considered a mainstream medical therapy as part of your arsenal for fertility preservation. And that's a huge push forward to have that recognized by the ASRM in that way. And then lastly, there's sort of the new frontier, which is probably in vitro maturation. And we can talk more about it. All I can say is that when Dr. Bedaiwy and I were residents together, this was going to be the next big thing. And that was over a decade ago. And it's still supposed to be the next big thing. So we're not quite there yet. I'm still very hopeful that we will get there. And I'll just touch briefly on it in a few slides. So as far as fertility preserving options, ovarian transposition is something that I do multiple times a year. It was classically thought of to preserve the reproductive potential of the ovary, but now I've had women who are in their mid to late 40s have no desire for another baby, but they want their ovaries transposed because they don't want to go into menopause and get hot flashes and bone loss when they lose their ovary and ovarian function. So now we're doing ovarian transpositions to preserve endocrine function rather than fertility. And that's actually a key area where we're thinking about using ovarian tissue transplantation, is that maybe a woman's own endogenous hormones can keep her from needing to take, estrogen pills to prevent hot flashes. So I think we have time. I'm going to play. This is actually my fellow operating. So this is the technique that I like the best for fertility preservation, which is for ovarian transposition. So the idea is that you're going to laparoscopically, I don't usually do these robotically unless there's a significant need, But usually what I'll do is a peritoneal tunnel. So here you're seeing that pelvic view of the uterus, the tube, the ovary. I'm looking at the anterior abdominal wall anatomy. So you can see there her inferior epigastrix. So clearly you want to place your port lateral to that. And then we can also kind of start to see, oh, we can probably speed this up a little bit. Here's where we're making the peritoneal tunnel above the pelvic brim. So we just retract the peritoneum enough to make 2 incisions, and then we're going to tunnel the ovary through that space, because one of the biggest concerns with ovarian transposition, knowing that radiation will be forthcoming, is that the ovaries can succumb to drift. So they can drop lower into the pelvis and then inadvertently be exposed to radiation. Once they're exposed to radiation, there's nothing you can do. So you want to make sure that you're using permanent clips or permanent sutures to keep the ovary in position. And then this addition of the peritoneal tunnel has been really effective for us in keeping the ovary transfixed where we want it to be. So here you can see my fellow coming through with the ligature, and basically the idea is to release the ovaries from its attachments. And you can do this on one side or both sides. I usually leave the fallopian tube in place. Some people transpose the tube with the ovary, but that's not my typical technique. And then if needed, and I've done this a couple of times, you can actually medially transpose the ovary back into place, years after cancer treatment is complete, if you want a more native state for the ovary. So there's the peritoneal tunnel. You can see kind of that color of peritoneum that we're going to slide the ovary through. You can also, if you look closely, see that we've identified some of the retroperitoneal structures. So you can usually dissect out the ureter to keep it out of harm's way, and you can look at your vascular anatomy of the retroperitoneal space. And so once we get this ovary mobilized, you'll see us bringing it through the tunnel. I wish I could speed this up for you a little bit. Oh, here we go. So there's the ovary, and it's been mobilized. You have to be very careful to identify and preserve the infundibulopelvic vessels, so the ovarian vessels. And then there's the tunnel right there, and you can either push or pull the ovary through there. So you can see us kind of maneuvering on the other side. And then that's going to be tacked into position, high above the pelvic brim and high away from where it would be at risk of having radiation-induced damage. And I think there's a key tip here, which you'll see us, ovaries are very slippery. So you have to make sure that you don't accidentally torse it or torse the vascular supply to the ovary. You also have to be careful when you're suturing with permanent suture like silk, that you are not compromising the ovarian blood supply, and that you're putting it high enough that it won't drift downwards. So the combination of sutures and the peritoneal tunnel, I think, are very helpful in keeping that ovary staying put. I also usually will mark it with surgical clips. So when they're doing their radiation planning, they know exactly where the ovary is, because those clips will show up on any kind of imaging. So I'll probably pause there. You don't need to watch the whole thing. But just to kind of give an idea of our technique for that. And the nice thing about that, this is another video of a bilateral transposition, but you can imagine the same thing just on 2 sides. But this technique, if it's done correctly, has an over 80% success rate of ongoing ovarian function. And so I think that that is something really interesting that we can pretty easily provide to patients to keep their ovaries up out of the field of radiation. Now, the problem is oftentimes it's not just radiation. These women are getting chemotherapy. And when they get the chemotherapy, of course, that will affect ovarian function. Now, I can't take credit for this work. I've done a lot with uteruses and certainly could talk to you about uterus transplantation, but this is work that came out of another group with the idea of if we can transpose ovaries and keep them out of the field of radiation, can we also transpose the uterus? Because again, there's this increased awareness that radiation therapy is associated with uterine damage. And it's probably, we know that the uterine volume shrinks, that there's more fibrosis within the myometrium, that there may be vascular damage and endometrial injury. And, the endometrium is essentially its own organ, and it's incredibly complex and pivotal in implantation. And so if that area has been damaged, again, there's not a lot that can be done. So can we move the uterus up out of the field of radiation? And that's what Ribeiro and colleagues did in 2017. And this is something I've followed with great interest, and I'm really interested to see if it can be done at our hospital. So the idea is that you mobilize the uterus, bring it up out of the pelvis, and then actually they anastomose the cervix to the umbilicus to allow menstrual efflux to come out of the umbilicus. So pretty creative. And this is their setup here. Again, I don't know that I can really show the whole video just in the interest of time. But here they are mobilizing the uterus, and I'll see if I can get you kind of through to the end result. All right, so let's start here. So they've mobilized the uterus from most of its attachments, and that's about where they want to fix it, right at the level of the umbilicus. And so then you can see that they're taking this mobilized uterus. The perfusion is still coming through the ovarian vessels. You have to take the uterine vessels, but then you can kind of flip it upwards. There's the uterus, and you can see that they're going to attach the cervix to the umbilicus. Those are all the stay sutures that are keeping it in the right configuration. So again, I can't show the whole video, but it's pretty fascinating to see what can be done. And this is after the MRI. You can see that the uterus is positioned up above the umbilicus with the menstrual efflux able to come out through there. But it is far away from the field of radiation. And I think the areas where this is probably going to be the most important would be cervical cancers, would be colon cancers, and then probably some pelvic lymphomas. So this patient who had this really interesting surgery, she had normal menstrual periods that came out through her belly button. And then 5 weeks after her radiotherapy was completed, they did a rectosigmoidectomy, meaning take out that diseased portion with the cancer, and the uterus was then repositioned back into the pelvis, and the anastomosis between the cervix and the vagina was reconfigured. So really fascinating work, groundbreaking work that's being done. And then another group further modified this technique of laparoscopic uterine fixation to basically just to bring it to the anterior abdominal wall and up as high as possible. And this is the MRI of their fixation. So this was the before, and then this is the after. And actually you can see it really nicely. And you can see where the tumor is based on this red circle. And so they should be able to now safely radiate, whereas they weren't able to do that before. So I think this is the next wave. Stay tuned. I think it's absolutely fascinating. And then this is the laparoscopic uterine fixation with ovarian transposition. And so you can look up the report from 2018 if you want to watch the video. I think I was told to try to keep it around an hour. So in the interest of time, I won't show that video. All right, so shifting gears, we talked a little bit about surgical options. Now let's talk about medical options. So probably the most important medical option for fertility preservation is the GnRH agonist. So in the United States, it's usually marketed as Lupron, which is leuprolide acetate, but there's many others. Goserelin is a commonly used one. I think it's important to recognize that this is controversial. Although I fall on the side of GnRH agonists, you should be aware that it's a debate. And the problem is that there's many systematic reviews. I believe Dr. Bedaiwy put out one of these. And the criticism of the reviews is that, what you get at the end, whether it's in favor or against GnRH agonist use, has everything to do with what articles get picked to go into the systematic review. We're dealing with lots of prospective studies that are small and uncontrolled. I don't think that anyone has the sort of last word on this yet. However, if you look at the Cochrane database review, it does favor at least consideration of a GnRH agonist. And in most cases, once you're considering something, especially when it comes to future childbearing, most people are going to fall on the side of, well, let's just give it, and what's the worst that can happen? So GnRH agonists, and I do believe this, should be considered for women of reproductive age, not children, who are receiving chemotherapy. And again, you have to have a functioning HPO axis for something like a GnRH agonist to work. And then my other criticism of the available literature is, again, these studies are not looking at the outcome that matters. The outcome that matters is whether you can get pregnant after chemotherapy. You need to look at pregnancy rates. You need to look at live birth rates. You cannot just look at who has menstrual disturbances or who loses their period after chemotherapy. That's not the outcome that we're looking at. So we really need prospective, well-designed studies with large numbers that have controls if possible, and that's hard to do. So I think this is the best of the bunch. This was published in 2015. When I was at Cleveland Clinic, we were a site for this trial, and it was published in the New England Journal of Medicine. So obviously high quality study. And what you see is that this was the kind of research we need. This was a multi-center, randomized controlled trial, hundreds of women, and they've narrowed their focus just to premenopausal receptor negative breast cancer patients. And that's one of the interesting things you'll see in the application of this data, is that we've kind of extrapolated it to be everybody, but they focused on a very specific subset of triple negative patients. Now, that said, they used goserelin, which is a GnRH agonist, co-treatment. And what was really interesting was that it reduced the ovarian failure rate, meaning somebody goes into premature menopause, to 8% versus 22% in the chemotherapy alone group. So again, these are the old metrics of like, does somebody have a period or not? But what was even more important about this study was that they also looked at an endpoint that really, really matters, which is who can get pregnant. And a good number of the women who were randomized actually were studied long-term for follow-up all the way to pregnancy. And so of those 218 women that were available long-term for evaluation, the pregnancy rates were much higher in the goserelin group. So not only did they continue having periods and good reproductive function, they actually were able to be pregnant, and they looked at live birth rates as well. So that was really encouraging data on GnRH agonists. That's what's colored my practice, and I will liberally use GnRH agonists in adult patients, especially with breast cancers. Now, interestingly, when you look at the literature, for example, on lymphomas, it hasn't really swung towards GnRH agonists. I will still occasionally use them, but at least the data that we have available doesn't indicate the same benefit as we have for breast cancer patients. And there's a lot of interesting discussion about why that may be. So similar to in the case that I presented at the beginning, breast cancer patients have a little bit more time for downregulation, which is the way that GnRH agonists work. So, initially there's a flare effect that's central. You get all this FSH and LH that's been released by the pituitary gland, but over time, those receptors downregulate, and then FSH and LH become wisp or soft, and therefore the ovaries, you really go into a hypoestrogenic state. And so that takes a little bit of time. With lymphoma or leukemia, they usually go immediately into treatment. But with breast cancer, oftentimes there's a surgery, then a few weeks, then chemotherapy. So it may have to do with the window of exposure to the agonists, or there may be other factors that we just don't understand yet. But certainly for breast cancer, there appears to be a benefit. For some of the bloodborne malignancies, we're not so sure. So let's switch gears now. We talked about surgery. We talked about medical therapy. Now let's talk about actual fertility preservation options. And that is always hand in hand with assisted reproduction. And so embryo cryopreservation is really the best of the best. This is the gold standard. You can see a beautiful day 5 embryo there. The part that's at 9 o'clock is actually the inner cell mass, which is what's going to make the baby someday. The outer rim of cells is the trophectoderm, which is what's going to become some of the placental structures. And then you can already see sort of a central clearing, which is going to be what makes the bag of waters. So an embryo at this stage is really golden. And implantation rates in the United States with a day 5 blastocyst that looks this pretty are probably 65, 70%. So especially in a young patient, having a blastocyst like this really gives you a good chance of having a baby. So this is the gold standard. The problem is this is of no use to my 12-year-old patient who hasn't gone through puberty yet. And also many of the women who are diagnosed in that 15 to 25 age range aren't married yet. And so in the old days, we used to tell those women to go out and find some donor sperm that they could inseminate the eggs with to create embryos, because embryos were so much better than just eggs. That has totally changed, and we'll talk about that. But it's important to know that embryo freezing definitely requires some sort of source of sperm. It also takes several weeks to complete. Sometimes in the context of cancer, we just don't have that time. And we've been doing this since the 1980s successfully, around the world. Despite that, there's not a ton of data in cancer patients. And I always tell my patients, whether it's for elective egg freezing or cancer egg freezing, what the data has shown is that most people don't return for their frozen tissues. Either they have no fertility issues and they're able to get pregnant on their own, or in some cases, they've decided not to have children, or in the saddest cases, sometimes people just don't have an opportunity to come back and use it. Either they don't want to become parents, or, some of my patients pass away from their cancers. So mostly we can counsel people about the chance of success based on egg donor cycles, because they're essentially functioning as an egg donor, but for themselves. And then just like everything in IVF, and this is a crucial concept forever and ever, your chance of success is mainly predicted by how many eggs you have, how many embryos, and what the quality of those are. And the biggest, most important prognostic factor is age. So I always tell people I would rather have a 20-year-old who makes 5 eggs than a 40-year-old who makes 20 eggs. And age is just so relevant in the reproductive success of those tissues. And so these are the slides that we all hate to watch in medical school. I don't know how many women are in the audience, but you just hate to see this, because as time goes on, the chance that you are going to be successful in having a baby shoots way down. And it actually stays pretty consistent until about the age of 37. It does go down until then, but at 37, that's really the biggest point of inflection in this curve. And you can see that from 37 and beyond, your chances dramatically decrease, to the point that, I can remember the names of the 42-year-old patients that I've had over the last 15 years that were able to get pregnant. Now, that's very different than what we see in the media when Janet Jackson is having a baby at 50. But in reality, women's ovaries and eggs are not programmed to be able to have babies, usually past the age of about 42, 43. So those are very few and far between, those success stories, even with the biggest, most powerful technology we have, which is IVF. And again, for those that ask me to touch on elective egg freezing, this is very important when we talk about that. Usually the panic point for women to come freeze their eggs is, somewhere in their late 30s. They worry that time is ticking, they haven't gotten married yet. But really the best time to freeze eggs is 35 and younger, again, due to the quantity and quality of eggs in that age range. Now, this is the opposite. So if you do get pregnant, what's the chance of having a miscarriage? So, reproductive success goes like this, miscarriage rates go like this, and mainly this is due to the effects of aneuploidy. And aneuploidy rates by age are mostly determined by the fact that those eggs have just been around as long as that woman has been around. And the mechanisms for successful cell division have really just diminished by the time we get into our late 30s and then 40s. So, if I have a 44-year-old who's lucky enough to have that miracle pregnancy, I have to be the one giving her the bad news that her chance of miscarriage is 50% or higher. Because even if you get pregnant, which feels like the biggest hurdle to the patient, the chance of a miscarriage is incredibly high. Pregnancy rates in donor egg cycles, which I know are not possible in some parts of the world, are much higher. And this really shows it's not the age of the uterus, and that's what we've seen with uterus transplant. It's the age of the egg and the embryo that predicts success. So we can see pregnancies in uteri that have been transplanted from women in their 60s that have been deprived of estrogen for years. But with the right programming, they can go on and hold a healthy pregnancy. And that's what we see with egg donors as well. The pregnancy rate stays totally solid, even though the rate of the uterus gets older and older. So one of the big changes in fertility preservation is that in the old days, we used to think that we had to wait for someone's normal menstrual cycle to come around before we could do their IVF and freeze their eggs or embryos. The newer protocols are called random start. And without getting too much into the details of this, this was really pioneered by probably the group at UCSF with Mitch Rosen. And really what they've shown is that if we just start a woman at any point in her menstrual cycle, we can get success within 2 or 3 weeks. We can get to the egg retrieval, and it does not delay their time to chemotherapy. So that's the biggest worry for a patient and her family when she's diagnosed with cancer, which is, let's get on with it. Let's get to the chemo, because I don't want any chance that my prognosis will be worse. And now we can show there really is no delay. Your chemotherapy takes 2 or 3 weeks to set up anyway. And it does not seem to be associated with any worse prognosis to go through ovarian stimulation. And so the reason that we've been, I think, so successful is that even for hormone sensitive cancers, we can use aromatase inhibitors to block estrogen production and keep those levels very low. And this has been studied specifically in breast cancer patients and uterine cancer patients, where the worry is the highest because those are very hormone sensitive diseases. So by using a random start protocol, by using what's called an antagonist protocol with a lupron trigger, I mean, really, we've been able to not increase risk in these patients for recurrence or for a worse prognosis, and it doesn't delay their needed chemotherapy. Now, egg freezing is a huge area for discussion. This could be its own lecture, and it's come a long way over the last 10 years. So just like ovarian tissue freezing is no longer experimental, egg freezing is also now gold standard fertility preservation and has been now since 2013. Same idea as with embryo freezing, though. You have to have gone through puberty. We need a couple of weeks to do it. But what I love about it for the women I see for fertility preservation is that there's no sperm required. And really, this gives a woman the most flexibility in choosing what is the future fate of her gametes. You know, is she going to find a partner that she wants to fertilize those eggs with? Does she want to use donor sperm? The sky's the limit, you know, once it gets to 5 or 10 years down the line. She can do whatever she wishes with her frozen eggs. And that's really due to improvements in what's called vitrification, which is the flash freezing of oocytes, as opposed to the traditional slow freeze protocols. So I can't tell the difference between an egg that's been frozen and then vitrified and a fresh egg when I look under the microscope. And their success rates are really getting pretty equivalent with fresh eggs. So this has been a huge game changer in our field. And so I wanted to take 2 minutes to talk about elective egg freezing because this was requested by Dr. Al-Hussein. This is a big part of my practice. More and more companies around the United States are paying for their employees to freeze their eggs, and worldwide there's tremendous interest in egg freezing. I think there's the sort of fantasy of it, and then there's the reality of it, and I see both in my practice every day. I love that people are talking about egg freezing. I love that women are thinking about this as an option for delaying their childbearing. At the same time, you know, there's a phrase in the United States, which is that you know, like a bird in the hand is worth two in the bush, which basically means we can freeze anything you want, but we don't know what the chance is that that's actually going to become a baby for you until you actually thaw out your eggs, fertilize them, grow them into embryos, and then transfer them. So my biggest worry is that someone freezes their eggs at 35, waits until they're 45 to have a baby, and then we try to thaw their eggs and help them get pregnant with it. And it may be that those eggs just aren't of a quality to do it. And at that point, her reproductive window is totally closed. There's no way to go back and try to get more eggs. So I think it's a good option. I just don't want women to have a false sense that they're pushing pause on their reproduction until a more convenient time, because the reality of egg freezing is that it can be a little bit unpredictable. So we've started to get better algorithms on what the success of egg freezing may be. And I always say 20 is the new 12. So when I started my training, we really thought that freezing a dozen eggs should give you a good chance of having 1 to 2 babies. And now really, I think 20 eggs is the standard. The problem is that not every woman can get there in one round of egg freezing. And so it may take 1, 2, 3 or more rounds to get to a pile of eggs that you feel like really could become a baby for you. And so this is a really helpful nomogram. And you can see, as with everything in reproductive medicine, it has everything to do with age. So, you know, in this model, you could freeze 30 eggs at age 44, and it's only going to give you a 21% live birth rate. But you could freeze only 6 eggs at age 35, and that'll give you a 50% chance that you're going to have a baby. So I really like this that's snapshotted here. I use this every day in counseling women about whether, when, and how many times to do egg freezing. And even with this, it's all modeling. You know, for that individual, we really aren't going to know until they go to use their eggs. So I'm happy to answer any questions on egg freezing at the end, but I think it's a good plan. It's not a perfect plan. And then just to show you some of the cool things that we do in the IVF lab, you know, we thaw out the eggs. You can see it positioned there, and then you can see the little pipelle coming in at 3 o'clock, and there's a sperm there in the pipelle. It's only, you know, a few microns compared to the egg, which is the largest cell in the human body. And so there you can see ICSI, which is a really advanced method of injecting the sperm into the egg. We've been doing this for 30 years. We know that it doesn't cause twins or birth defects. And the sperm is inserted into the egg's cytoplasm so that fertilization can occur. So that's what happens with the frozen eggs on the other side of cancer treatments. And you can see the sperm going in there. It's just amazing to watch what we can do in the lab. And then this is, I think, even more important, which is, think about a patient with BRCA, or some other cancer gene. We can actually pull away 5 or 10 cells from the trophectoderm now for biopsy, which is called PGTM, looking for specific genetic mutations. So once you've gotten your embryo, which is what you see there that has, several hundred cells, you can tease a few away, knowing that each cell should be a mirror image of every other cell. And we can then screen out embryos that have genetic mutations so that that woman can have a healthy baby that doesn't end up with the same cancer that she had. I'll talk very briefly about ovarian tissue freezing. Dr. Bedaiwy, do you want me to try to wrap up, or how are we doing here with time?
You just go ahead. You're doing great.
Thank you. All right. Well, if you need me to wrap up, let me know. So this is something I'm really passionate about, which is ovarian tissue freezing. And actually, most of the work on ovarian tissue freezing has been done internationally. It's only recently that the United States has caught up on this. So what's exciting about ovarian tissue freezing is instead of just freezing eggs, and I can freeze 5 eggs, 10 eggs, 20 eggs, you can actually take the whole ovary or a portion of the ovary and preserve thousands of follicles. And so, there are both malignant and non-malignant indications for doing this. And I've done all different kinds of patients. I've probably frozen tissue on almost 50 patients at this point, although I'll tell you, in the interest of full disclosure, because many of these are young patients, I still haven't had a chance to do a reimplantation yet. It's probably going to be another 5 or 10 years before one of my patients comes back and is ready to have their ovary reimplanted. But the idea is that you can take the whole ovary or part of the ovary, then freeze that for the patient. They go through their cancer treatment, and then on the other side of their cancer treatment, that ovarian tissue can be reimplanted. And there's a number of different ways to do that. And that the normal hormone axis from the hypothalamus and pituitary gland will wake up, the eggs and follicles on the ovary. So the biggest concern, especially with the hematologic malignancies, is that you could potentially be reimplanting tissue that contains malignant cells. And so there are people who are better or not as good candidates for this treatment. It's probably most helpful for children that are prepubertal and just don't have an option of doing egg or embryo freezing. But I have also done it for pubertal women, especially when time or cost are such significant concerns that they simply cannot access egg or embryo freezing. So it's really available to anyone. And this was a really happy day for us in the fertility preservation world. In January of 2020, the American Society for Reproductive Medicine finally lifted the experimental designation for ovarian tissue cryopreservation. So making this a mainstream gold standard treatment for women who may not have other options. So if we look at the current state of ovarian tissue freezing, and this is similar to uterus transplantation, it's come a long way over, a short couple of decades. So the first live birth was in 2004, so really only about 15 years ago, but suddenly now we've had this proliferation of births. I think we've kind of lost count, but there's at least 150 live births now around the world from orthotopic tissue reimplantation. Now compare that to IVF, where there's probably 7 or 8 million babies around the world that are born from IVF. I mean, this is still a far cry from that, but I think it has incredible promise. And I think as we start more reimplanting, we're going to start to understand better what the true success rate is from this technology. Typically right now, even though the experimental designation has been lifted, in the United States, we do this under IRB approved registries, just to make sure that we are tracking carefully. So as we gain experience with ovarian tissue freezing, it's really interesting to find that these patients can often become pregnant without IVF. About half of the live births that we've seen are spontaneous pregnancies. So when we look at large registries, about half of the women who undergo ovarian tissue freezing will be able to become pregnant, and about a third will achieve a live birth, meaning that there is, a miscarriage and pregnancy loss rate. Most of the success that we've seen so far is from adult women. But there's a 2009 systematic review that looked at 1,000 patients, ranging from just a few months all the way up to 20 years. And they transplanted tissue from 18 of them, and 10 of those did have a live birth. So I think that's good to note that these patients that froze tissue, especially in childhood and adolescence, young adulthood, were able to have success. There was an important first in 2015, which is that we finally were able to get a live birth from someone who froze tissue before puberty, which we didn't know if that tissue would be able to be biologically active. And now actually there's a report even of a 9-year-old that came out. So we know now that the ovary will respond to all the normal hormonal mechanisms to have folliculogenesis and ultimately pregnancy, even if that ovary was frozen when that person was a child. And Dr. Bedaiwy did some work on this when we were residents, and I know he's continued in the fertility preservation research that he's doing in trying to figure out where is the best place to re-implant the tissue. Should we take the whole ovary? Should we take part of the ovary? And I think the fact is that one, no one really knows yet. It's still a very new field. And two, what's reassuring is that the ovary, much like the uterus, is incredibly robust. You can do a lot of different things with the ovary. You can cut it into strips. You can take the whole ovary. You can put it into a peritoneal pocket. You can sew it back onto the ovarian stroma. And generally, because ovarian tissue is so active and so angiogenic, you can do almost anything to the ovary and you can get reactivation of follicles. So this is really, really exciting. I don't think any particular method has emerged as the top. And there's a lot of active research in this area, but it's very exciting. And I would say the major limitations right now is that we're still having long-term data accumulate. So there's really only 2 live births that have been reported from frozen tissue in girls that had not gone through puberty yet. And we haven't had any live births from like the forearm implantations, heterotopic reimplantation. There have been 2 live births from the peritoneal technique, which is what they do in Israel. So it's currently not indicated for induction of puberty or long-term endocrine function, even though there's a lot of discussion about the hormonal benefits of reimplanting your own ovarian tissue. And that's because of essentially what's called graft burnout or follicular burnout, which is that these implants don't have the same lifespan as the native ovary, as the ovary that hasn't been removed, frozen, thawed, reimplanted. And there's a lot of interesting ideas for that. I won't go into it today, but it seems like most grafts last about 3 to 4 years because of this phenomenon of burnout, and some may last up to 7 years, but in general, it's not going to be something, that is active for the life of the patient. And there's many who believe that maybe you implant a few strips and then 5 years later you implant a few more strips, because if you freeze the whole ovary or strips made out of the whole ovary, you may have enough for multiple implantations. So there are selection criteria that you can use if you're building an ovarian tissue freezing program. This was put forth in Lancet Oncology in 2014. I personally haven't been able to stick with this because I think our feeling in the United States may be a little bit different, which is, what is a realistic chance of surviving for 5 years, and what child or person are you going to say no to based on their prognosis when that family is looking to you for any hope? So these are really hard discussions to have, but I would say just to be aware that these criteria are out there. So this is the way that I used to do my technique, which is just shaving off the ovarian cortex. These are pictures from a surgery that I did. You know that the white part of the ovary, the cortex, is what contains all of the eggs, and then the internal portion is connective tissue, blood vessels, and stroma. So I used to do this technique, and I would say I've adapted my technique over the last 15 years just to removing the whole ovary. And I'll tell you why. But when I used to do it, this is how I would do it. I would sort of decorticate the ovary and then flatten it out like a pancake so that I could cut it into strips in the lab. And this is just very typical of what it looks like. Probably to the best we understand, it should be about 10 millimeters by 5 millimeters, 10 millimeters long by 5 millimeters wide by like 1 to 2 millimeters thick. And you guys have seen how thick and rubbery the ovary is. So it's very, very hard to thin the cortex down thin enough. And I do it all by hand. And so I've started to just remove the ovary, bivalve it, and then thin it down in the lab. This is a nice animation of what it looks like to remove part of the ovarian cortex. There it goes, cut it into strips, reimplant it. And the reimplantations, are typically done robotically because of the fine suturing that's required. So that's one option, is leaving the native stump of the ovary and just quilting it back onto there. The other option, which I think is going to play, is to take out the whole ovary. And this is how I plan to reimplant now, which is essentially just to open up a peritoneal pocket and reimplant it in that area where I know it's going to be able to develop a good blood supply. And I didn't include it in this talk, but a fellow of mine and I did a study using sheep, comparing the different methods, and all of them had significant angiogenesis, whether we left the ovary or we didn't, used a peritoneal pocket, cut it into little cubes or strips. The ovary is just incredibly angiogenic and incredibly resilient. And so I think this is the same. So this is Sherman Silber's technique. He does it by mini laparotomy. That's totally fine. And you can see how he's removed it and then re-quilted it on here in D. It's a beautiful surgery. And he's done a lot of studies with identical twins showing reproductive success. That's the final version. It looks like it was never gone. And then this is Jacques Donnet out of Belgium, who uses the quilting technique, and you can see the sutures there. So very fine surgery, but certainly possible to do. This is the technique that Dror Myro uses out of Israel to open up a peritoneal window. And this is my little 6-year-old. So this is the youngest person that I've done it for. Here's her little tiny ovary that I'm preparing in the dish, and that tissue is still frozen now about 5 years later. So it's going to be decades before she's ready to come back for her frozen tissue. And I don't know that I'm going to play the whole video because you probably know what a laparoscopic oophorectomy looks like, but it is absolutely different operating on kids. I mean, I was happy in this 6-year-old that I could even find the ovary, because sometimes it's so small that you cannot. But here it is being removed, and we were able to just take it out through the umbilicus, cut it into strips, and then freeze it. And then this is what reimplantation looks like in an animal model. So as I said, like I'll admit I haven't done a reimplantation yet, but it's a lot of very fine suturing. That's the stump that you can see there. And then you're going to see us passing in fragments of the ovary. In fact, this might have been one of Dr. Bedaiwy's surgeries, that the video has been passed along to me. But here's where you can sew them on very finely with fine suture. And again, it's not a particularly bloody surgery, and the ovary just has incredible potential to implant there, start growing, and then for that patient to have a totally natural pregnancy, without IVF necessarily. So again, just fascinating what we're doing and what I think we'll be able to do over the next few years. So this is kind of the final frontier, I think, is in vitro maturation. And there was a live birth that really shows proof of concept that maybe what we can do is get frozen ovarian tissue and then instead of reimplanting it, find ways to grow out immature eggs from that tissue in the lab. And really the biggest benefit is that we always worry that we're going to put cancer cells back in when we do a reimplantation. And so this really gets around that concern. So we do have a live birth, but we don't have an accumulation of live births really to know for sure if this will be successful. So I think this is exciting and sort of under that what's new category, but I'm not sure that I can say it's ready for prime time. Okay, so just kind of wrapping up, and then I'm happy to take anybody's questions. For both of my breast cancer patients, both the newly diagnosed patient and the previvor, we elected to do egg freezing. And then what I think is a very important concept in fertility preservation is that you don't have to just choose one or the other. In fact, many patients are candidates for multiple options. So she froze eggs, but we also did give Lupron during the chemotherapy that the first patient underwent. And then for the patient that's a BRCA carrier, we elected to counsel her regarding prenatal genetic testing for her genetic mutations so that her children don't have the same risk that she does. And then she ended up doing risk reducing surgery. So, once they get to a certain age, they recommend having their ovaries removed to reduce their risk. So we will talk about whether to do ovarian tissue freezing at that time. If the ovaries are coming out anyway, we may as well freeze them for them. And then lastly, especially with my 23-year-old, that's that conversation about expedited pregnancy. She was going off to law school or something. And I made sure that she knows there's not a perfect time to have a baby. Once you're in a position with your partner, don't wait because of school or something else, because there is that risk of cancer diagnosis looming. Same thing with my 29-year-old with the colon cancer. She actually did two things. One ovary we transposed, the other ovary we removed and froze tissue. And then, I wish that I had known about ovarian or uterine transposition at that time, because she would have been a perfect candidate for that. So I'm very anxious to try that with the right patient. But for her, because the uterus was radiated, she may need to use a gestational carrier in the future. And then we talked about ovarian tissue freezing for my 6-year-old, and I'm still in touch with that patient and her family. So I think that brings us to the end. It's kind of a whirlwind tour of fertility preservation, but thank you for bearing with me, and I'm happy to answer any questions that you might have.
Well, thank you very much, Rebecca. That was very informative and detail-oriented as always, and up-to-date as well. You threw a few questions, and I'll answer them quickly until Professor Mahmoud joins us to handle the questions. So unfortunately, we don't have funding in BC for IVF or public health system. We just did the first ovarian tissue freezing case in BC after a lot of years of trying. So it's, we're very happy to see that the ban is, well, the experimental label is lifted, because this will help. Unfortunately, patients have to come up with a cost, because some of the local fertility clinics are really helping by subsidizing the cost of the cycle, and drug companies are helping for those patients who wants to be stimulated and freeze eggs or embryos by donating the medications. Just probably you're aware of that, but not included in your talk. There was a very nice paper that was published in the New England Journal of Medicine about IVM, in vitro maturation, and they're really reporting great outcomes. So hopefully that would be they used a different protocol. So hopefully that would take on, and it will be replicated in other centers, because that was a major limitation of earlier attempts. So with that, I'm not sure if Professor Mahmoud is with us or not. So
I believe so. I think I see some questions. That's very exciting that you were able to get that through. It takes a long time to get IRB approval in any institution. I think it took, several years when I was at Cleveland Clinic, and now having moved hospitals, I'm going through the same thing at my new place.
All right,
so you really have to have a passion for it.
I can start reading the questions that I can see. So there's a question here: does cancer treatment affect the quality as well as the quantity of eggs? I think you answered part of that, but how about quality?
Yeah, happy to answer, and I'm sure you can fill in with your expertise also. I think that in general, we are having an understanding that it's all or nothing with cancer treatment for an individual egg. So if you think about all the eggs in your ovary, there are some that will be affected by cancer treatment, and those are done. And then there are others that will not be affected by cancer treatment, and those tend to go on, be healthy, normal, regular eggs. And so I think many women are worried that cancer treatment is going to damage their eggs, resulting in abnormal babies or babies with syndromes, problems, cancers themselves. And at least to the best that we understand, it's really all or nothing, that eggs, certain numbers of eggs will either be wiped out or they won't. But if they continue on, they should be healthy. Dr. Bedaiwy, is that your experience overall?
Well, very much the same, because the eggs are the eggs. Once they survive, they survive. Actually, the major factor that affects them is the age, unfortunately, and that's something you cannot change. There is another question here: does survivors of cancer who will proceed to fresh IVF cycle can benefit from BGS, which is now BGTA, for aneuploidy? And are they at a higher risk than their age-specific risk?
Yeah, that's a great question. And I don't know that anyone has actually looked into this in a rigorous way or that we have the answer. But I would say that the general thought is that women who've been exposed to cancer treatments, again, because it's all or nothing, that their risk is mainly age related and not so much cancer treatment related. So we don't think that cancer treatments affect mechanisms of eggs for, for example, infertilization or cell division that would result in aneuploidy. So I don't think that specifically cancer patients are being counseled to do what we used to call PGS or PGTA. However, any patient can choose to do it. And as you know, there's a huge debate about the utility of PGTA. There was a large randomized study that was published called the STAR trial that I'm sure my partner, Dr. Wienerman, is going to talk about when she talks about what's new in IVF. So I won't go there right now, just to know there's a big debate, but the bottom line answer is no, I don't counsel cancer patients specifically that they would need to use PGTA. The time we talk about it most would be related to age or if they have a cancer syndrome that we know is inherited.
Okay, so there are a few more questions. Some of them we can answer quickly. So how long can you freeze eggs? Basically forever until they are ready to use them, I guess. The next question is, how would you do ovum pickup in unmarried version, transabdominal or laparoscopic?
Oh, what
Well,
a great
more of a
question.
cultural question.
No, that's terrific. I actually had another lecture that I helped put together on sort of like cultural differences in IVF practice. So this is perfect. And I think the short version is I once wanted to do a laparoscopic egg retrieval and they could not find the instruments at our hospital. It had been such a long time since a laparoscopic egg retrieval was done that we couldn't even get the equipment. So I would say most of us, in cases where vaginal access is not preferred or prohibited, will do transabdominal egg retrieval. I've done dozens of these for reasons just like that, or sometimes a young patient, who's never used a tampon before, or especially for my uterus transplant patients who essentially didn't have a functional vagina initially. So transabdominal is a perfectly good approach, and we've been able to get a high yield of satisfactory eggs that way. So that would be my approach with that particular patient.
Do you change the suction pressure of your pump differently from the transvaginal retrievers when you do transabdominal Rebecca, or you
So
use a setup?
usually I will set it as the same as for like a single lumen, because I'm not flushing if I do transabdominal. We're just trying to get in and get out. So I would use it similar to what you use for single lumen. What do you do, Dr.
Well,
Bedaiwy?
I am not a big fan of flushing, but my question is actually about the pump pressure. Usually set it around 100 to 110. So do you change? That's my question when you do. I did not really do any abdominal retrievals. Didn't have a chance to.
Yeah, I
I
think
mean,
100 is a safe bet. I mean, if I'm having trouble getting it, I might crank it up a little bit, but no, 100 I think is fine.
so the next question here, what is the role of serum AMH in following up these patients? Which probably the person who's asking is probably trying to ask you, do you do serial AMH assays in patients with who probably were exposed to chemo radiotherapy?
Yeah, so that is and I think that's Dr. Mahmood. Um, it's such an interesting question. So I think there's increasingly an awareness of the limitations of AMH, both in cancer patients and non-cancer patients. So for example, there was an excellent study published by Ann Steiner a couple of years ago that showed that AMH is not a fertility test, meaning it can tell you what is the population of background eggs that you have. It may to some degree predict age of menopause, but when you take all women trying to get pregnant right at the outset, no infertility diagnosis, AMH in no way predicted at any age what someone's ability was to get pregnant. And I think that's so important because I see patients every week with their AMH printed out who come in tears, all my eggs are shot. They've never tried to have a baby. And I do a ton of reassurance that this number, does not predict whether you're going to be able to have a baby. It's not a fertility test. It is useful, though, in helping me figure out how aggressive of an IVF protocol they need, what doses and combinations of medications, and it does predict how many eggs and embryos they may get. But in most patients, we're only transferring one embryo at a time anyway. So they may not get a whole lot of extras, but they probably have enough to get them to a pregnancy. Anyway, to answer your question, an area where we are particularly aware that AMH is poorly predictive of outcomes is the cancer setting. So we know that AMH plummets after cancer treatment, but it doesn't actually predict which of those patients will necessarily be able to have a baby. And there is somewhat of a rebound phenomenon after cancer treatment. So I think, again, sadly, the answer is we don't know for sure, but that I wouldn't hang anything in your counseling on a particular AMH level, because I have a patient with an AMH of like 0.0006, and she has had 2 babies since her cancer treatments. So it's absolutely not someone's destiny as far as whether they'll be able to have a baby.
Yeah, I agree. It's sad to use just a mere number of an assay to predict the patient about the outcome in terms of live birth, given the so many players in the area. So there's an ethical question here, Rebecca, which is a very good one, actually. For children who are candidates for fertility preservation, what happens if their guardian refuses to let them undergo fertility preservation? How would you handle a situation like that?
Yeah, that's a great question. And, ultimately, it is the decision making of the parents. And so it can be very difficult when you have a child who wants something different than their parent. We actually had that recently. It was a 16-year-old who really wanted to freeze her eggs, and the mom was not comfortable with any risk to her daughter. And of course, egg retrieval is a surgical procedure. There's no zero risk egg retrieval that I can offer. And so it actually did go to the ethics committee, who met with the patient and their family. And usually we can get to some kind of common ground. And that's what ultimately happened. The mom was able to proceed, and we froze a good number of eggs for her daughter. But if the guardian absolutely refuses, there's not really a mechanism for being able to do fertility preservation, because ultimately that's the person who's making decisions.
Next question I see here, why bone marrow transplant is a high risk if I understood the question correctly, because they use conditioning chemotherapy in the beginning, so they destroy the old bone marrow and transplant new. Do you want to add anything to that, Rebecca?
No, that's exactly right. It's not so much the transplant itself, it's the induction chemotherapy, because they have to get the patient to hear before they can do the transplant. And so part of this process essentially wipes out all the eggs in the ovary. There have been some reports of patients, especially very young patients, who've been able to achieve their own biological spontaneous pregnancy after bone marrow transplant. So it's possible, but it's a very high risk treatment.
Well, as a follow-up to this question, did you come across any patients who have conditioning chemotherapy, umbilical cord stem cell transplantation, and then tried to get pregnant?
Yeah, I have. I can't say I've seen a lot of success. Have you?
No, not really. That's why I'm asking.
Yeah, sadly, no.
All
Maybe
right.
you and I will get there and we can publish about it.
So there is another question. How can surgery affect uterine function? Probably he's referring to the uterus fixation surgery.
Yeah.
Did they report any pregnancy or live birth rate after?
No, I don't think we have that data yet. But I think the fact that the uterus has, continued to grow a healthy endometrium, menstruate regularly, no complications. I mean, I think the most fascinating thing about the uterus transposition is really the knowledge that the uterus can survive, perfuse, thrive, just with blood supply through the ovarian vessels and then the collaterals that come down the lateral surface of the uterus. And that's been very interesting to us with uterus transplant as well. There have been times when only one side of the graft has perfused, and it's amazing to see some of the angiography studies that show how the uterus is able to, just from a single blood supply, be completely functional, healthy, normal, and give rise to a live birth. So I think the uterus is, one, very resilient, and two, very accommodating to flexible blood supply. As long as you've got some blood supply, the collaterals will allow perfusion and function.
All right, I think I got most of the questions in the that were posted in the chat. I'll add few questions from my end. So Rebecca, uh, I'm not sure if you consider the endometriosis patients as quote unquote previvors, or you try to counsel them, particularly those with stage 4 disease. Can you share with us your experience on counseling patients with severe endo regarding their options, basically?
Yeah, so I think this is a fascinating topic, which is, this is not a cancer, although sometimes endometriosis can be as bad as a cancer or worse. And so those are women that we know are at risk of multiple invasive surgeries that can affect both function, reproductive function, the ability of the egg and sperm to get together in that scarred and inflammatory environment, and also just decrease your egg supply. And all of us that do advanced endometriosis surgery, like even in the most delicate hands, it's amazing to see what happens to the AMH after some of these deep dissections that we do. And so the question has become, and I don't think we have any good society guidelines yet about this, are these women good candidates for fertility preservation prior to surgery? And I don't know that we have any really clear directive, but I start to talk to any patient, basically after a first endometriosis surgery, and now they're thinking of going in for a second. If fertility preservation is something they might want to start thinking about doing. And also any woman who's of older reproductive age, maybe we should actually go in and freeze eggs before we ever go in and do a single surgery. Do you have like a standardized approach, Dr. Bedaiwy?
Not really, because not based on data. Well, the good thing that we started to see, the EVE group from Spain already published their experience about patients coming back and utilizing their eggs data that we didn't use to have in the past. But when I see bilateral endometriomas, really I look around the ovary to see if there's a rim of antral follicles. I don't touch them until I talk to the patient extensively about their possibilities, and if they want to consider an IVF cycle with egg freezing or embryo freezing, if they are married before they undergo surgery, because sometimes surgery is inevitable in them. So I throw in the discussion, and what I like your terminology about expediting pregnancy. That's what I always tell them first. If you have a partner, you're considering to have a child with them, go ahead right away. Luckily, I'm not sure, luckily for them, we have a long wait for surgery here, up to 1 year. So I said, well,
Oh,
probably,
you're kidding.
yes, it's,
Wow,
it's
that would never
really,
happen here.
we got hammered extensively also after COVID-19 because they are pulling a lot of resources towards
Yeah.
COVID patients. So we're not getting as open of an access to OR like what we used to. It's not like the US, Rebecca, where you go to take the patient to the OR next day or
Right.
next week. So yeah, so I told them, please surprise me and tell me that you're pregnant on your own, and we can cancel your surgery. We can do it later after you deliver. So
Well,
I think, yeah, promoting natural fertility if they can while they're waiting for their surgery would be great. But that is if they are not open for the possibility of doing IVF for
I
a set of
totally agree. And I think the other interesting thing, and this has been promoted by Jacques Denet out of Belgium, is the idea that, perhaps when we go in and remove bilateral endometriomas, like if you ever go to your pathologist and look at the pathology, there are always follicles in the pathology. So, like, would there be some way to take those specimens from the OR and be able to actually preserve some of those immature eggs that we've accidentally stripped out of the ovary with our endometrioma stripping? So I would love if we could somehow find some way to combine their clean out surgery with some method of fertility preservation.
hopefully the work that's coming from Chicago. I'm blanking on the name of the person. She's your friend.
Oh, Teresa Woodruff?
Exactly. So
Yeah.
would probably provide a vehicle to utilize those eggs that can be scavenged or harvested after. And from earlier work we did in Cleveland when I was there, the ovary can sustain ischemia for a reasonable amount of time. So after you retrieve whatever ovarian cyst you have, if there is a method to look quickly and see if there is any pieces of ovarian tissue that can be saved and cultured. I don't wanna close this before asking you a very important question, Rebecca, which will be quite valuable to all the audience in the Middle East, because that field is starting to develop. I just wanted you to share your experience, first at Cleveland Clinic and currently at the UH, and how to set up a fertility preservation protocol, not only from the medical perspective and from what do we do for the patients and what protocol to use, but the logistics, number one. Number two, the financials. Number three, the initiatives that comes from the society to support those patients. I think these are quite valuable experiences, particularly for people in the audience who are thinking to start their own fertility preservation program, be it in a hospital or be it in a private practice.
Yeah, that's a great question. So, I don't know that I'm an expert in this, but now I've done it at two different places, and probably better than anybody, it takes quite a lot to get this off the ground. And I think one, it takes somebody who really has this as a passion and a focus. It's something that's very hard to do in your spare time. So to have someone, and it could be a pediatric surgeon, it could be a cancer specialist, it could be a reproductive specialist like me or Dr. Bedaiwy. But somebody has to kind of own it. And I think it starts there. And then, just know that you're not doing it alone. There actually are toolkits that are available both from the ISFP, which is the International Society for Fertility Preservation, as well as the Oncofertility Consortium, which is based out of Teresa Woodruff's lab, but has multiple participating sites both in the United States and national or internationally. And so many of those places have toolkits and even like IRBs that you can copy paste and use yourself. One of the things that was helpful to me was talking with people from around the world that I met through the ISFP. So Klaus Anderson, who's in Denmark doing it, Jacques Donnet, who's in Belgium doing it. I mean, ours is a very small world, and I think people are overall very approachable. You can certainly contact me if you'd like to. And I think people that have done it are probably some of your best assets. And then, for IVF and egg retrieval, embryo freezing, that's stuff that's done everywhere. And it's not really that different. There's a couple of good articles on Random Start that you can look up. One of the authors is Kakmak, Kakmak. I might have sent that out, and if not, I can supply it for you. And the other, I think, is Mitch Rosen, just looking at how to get cancer patients to IVF faster using some of these new protocols. So I think those resources are very helpful.
The
The
financial
other,
piece.
what was that?
The financial piece.
Yes, so that has been particularly hard for me, and I think for everyone. There's a number of charitable organizations that you can mobilize, like at a local or a regional level. I personally have tried to develop relationships with some wealthy donors at our hospital who may have a passion for cancer. I mean, once you start talking about cancer and kids, you'd be surprised at how much attention you can get, because so many of us have been touched by somebody who's had cancer and has a personal connection. But I wish I could say there's some really easy access to funding. Oftentimes it's discounts through the drug companies. I was able to really negotiate successfully for a 50% discount on all oncofertility at our hospital. It's not free, but it's better. So again, I think there's lots of little ways that you can work on it, but there's no really easy to access mechanism that makes all of this free or more affordable for our patients, which is unfortunate.